Dr. Ashvin Agarwal, I'm sure we all know him and doesn't need introduction. He's the Executive Director and the Chief of Clinical Services from Dr. Agarwal Eye Hospital, based at the Chennai Main Hospital. So let's hear what this very innovative surgeon has to show to us. On to you, Dr. Ashvin.
Thank you so much, Dr. and the whole team to actually pull off something like this. It's beautiful. So yeah, let's go. Can we start the video? Yeah. So this is my challenging case which I encountered, and I think Dr. Chitra was very clear. Do not show me a glued IOL case. So this is not a glued intraocular lens. But the idea of this showing this case was basically there's this phakic IOL of this for this patient, but the patient had ended up with 660 vision and was not happy with this phakic IOL. Two reasons. One is there was a huge amount of astigmatism on from the corneal side, which was not being covered by this ICL. This surgery was done a while back, and the patient was completely unhappy about it. That's one of the tricks that I wanted to show was how do you remove an ICL. I really don't pull it out into the anterior chamber so much. I basically just grab it just an edge up, and I grab that ICL to remove it. And it is such a beautiful material, the Collamer, that it really just comes out of just a 2.8 incision. Post that, I think the cataract portion, I don't think is challenging from most angles for most surgeons watching this or on the panel over here. But the idea of showing this case was a couple of things. One is how do you treat this patient post-operatively, because the patient is coming to you for astigmatism basically. So I'm doing a toric IOL implantation, but that sometimes is not enough in these cases. And what happens over here is basically, I'm putting a normal IOL in this case, and I'm going to show you over here how I'm basically taking care of that astigmatism using a pupilloplasty technique. That is a pinhole pupilloplasty, where I'm basically removing all the aberrations of the cornea, not at the corneal level or at the lenticular level. I'm basically trying to treat it at the iris plane. And if you see the, I'm sorry if I lost my audio. Yeah, so one of the things over here is to do a pinhole pupilloplasty using the single pass 4-throw technique. And what I'm trying to do here is, and that iridotomy is from the ICL surgery that was done long back. It's not created or iatrogenically created right now. Basically, I'm covering. What happens sometimes is when you close the pupil over here, you sometimes kind of get a shrunken, a small pupil which is not round. So sometimes what you really have to do is, after doing an irrigation aspiration, take off all the viscoelastic, because that's the real test of your procedure. So I'm putting a AC maintainer, and using a vitrectomy cutter, I'm basically trying to make this pupil a little round. Once I make it round, my edge to check where is the pupillary or the visual axis, this can be a little bit misguiding. So you'll probably want to put a mark beforehand. Is using the first Purkinje image, match the first Purkinje image to the pupil and that central mark which you basically created prior to surgery. And once you're done with this, you get a beautiful result post-op day 1 itself. And this is something that we published, as well as we've been doing this for a while. But this is an idea in a challenging case, which I think a lot of people will take benefit out of, because we have these IC8s and the other IOLs, or the sulcus, pinhole IOLs, which are coming up, but they're still very expensive, number one, and they're not available. So what do you do till they become available, and how do you do it for these patients who are really struggling but are unable to afford it? So these are some of the scenarios where you can really use this. And I'm happy to answer most of the questions which I think Dr. Chitra will come up with.
That was a wonderful, very different thought process, typical of you, Dr. Ashvin. But coming down to other ways of dealing with it, we all are aware that if it's a toric IOL to be implanted, you need to have an orthogonal astigmatism. So what are the thoughts of the expert panel that if it is a little irregular in the 3 mm zone, would you consider doing a topo-guided surface regularization and then putting a toric IOL? I would want your inputs too, Anaga, on this. And Yes, about that, I would want to know. And the other question is also, um, if it is a very irregular pupil, have any of you thought of using a contact lens on that irregular cone to make your phacoemulsification easier?
So I think, Chitra, I would agree with you completely that there are sometimes, severe ectasias where you are trying to do a cataract surgery. And if you don't use a contact lens on the top of the cornea during the surgical procedures, the whole things get so distorted that you can't make out, what is the real depth at which your phaco probe is, and at what level is your irrigation aspiration is. So this probably will not happen in cases where the astigmatism is less, but would happen in cases where the astigmatism is severe. And also, if it is severely irregular, then again this may happen. So I have done about 10 cases, 12 to be precise, using a contact lens for these severe ectasias. Regarding the topo guided regularization, I think I would agree with you completely that if there is some amount of corneal astigmatism which can be tackled by first regularizing it using a topo guided treatment, we would stabilize the cornea first and then take a final call on what the power of the toric intraocular lens would be. And I pinhole pupilloplasty is a very good procedure, but I think it is still evolving. And although by just making the iris, making it into a pinhole, you can get rid of all the aberrations. But when would you want to do it, and when you would want to avoid it, is something which one needs to look at.
Couldn't agree more. Couldn't agree more, Dr. Mamrita. I think that's completely right, rightly said, because I think there is value in what we are seeing today, but how much and in what cases the selection is vital.
The other thing is, Dr. Ashwin, by using a retractor, you have tried to enlarge the pupil, no? Do you think these pupils would dilate well in future for a retinal examination?
I think that's a brilliant question. So, if you use the vitrectomy on the side where you're using the vitrectomy on the pupil, I think that side may not dilate as the opposite side might dilate. But again, having said that, these are those worst case scenarios where you don't have an option. So that's what I'm trying to get at. That you don't have an option. The patient wants to see the best. I mean, most of his time, the retinal investigation is something that we want. Yes, I completely agree with that, and I think that's also important. But at the end of the day, we want to also take care of what the patient.
Yes.
We want to take care of what the patient really wants.
I think for the purpose of the viewers, I mean,
Sorry.
please understand that the best way to rehabilitate a keratoconus patient visually is contact lenses. If a scleral contact lens or rose scale lenses will give them good vision and they are able to tolerate it, that's the best way to go with it. It's only in cases where the keratoconus is stable and they are intolerant to wearing contact lenses or the vision, then we go in for phakic intraocular lenses, usually toric lenses. And in these situations, it's extremely important to make sure that the cone is well centered. And how do you make out it's well centered? The posterior float should show that the nipple is within the central 3 millimeters. It's outside of that. The optical axis of the lens that you put in and the optical axis of the cornea is not going to be in sync. And that's when even contact lenses will not rehabilitate these patients adequately. And in my early days, I even explanted 2 toric ICLs because the patients were not happy with the kind of vision that they had compared to what they were enjoying with the contact lenses before the surgery was done. So this is something you need to bear in mind. And of course, this pinhole pupilloplasty is something Ashwin has been promoting, seems to be a beautiful concept. Just a question to you, Ashwin, you seem to be putting in a toric intraocular lens. Is it really necessary when you have a pinhole pupil? I mean, will the cylinder also be taken care of with the aberrations?
So that's a brilliant question, sir. I think the point over there is we want to be sure in the first few cases was what we did. That was one. And the point which I will say is in this case, I made a mistake. I should have said it before. This case, I put a normal IOL. I didn't put a toric one in this case. The specific case, I just put a normal IOL. I said it wrongly. But the point over here is in the first few cases, what we did is we actually put in the toric IOL and then did the pinhole pupillary because we wanted to see what the result is with that. And we compared it with this. I think we didn't see too much of a change at all with regard to which IOL you put in. But I think the number of case samples that we've done is a bit too small today to actually comment fully on that in the comparative this thing, because there were only 2 and 2 cases. That's not enough. I think we need to do a lot more comparative studies on this to compare whether you have to put in a toric or not.
Satyajit, would you want to ask any question at this point?
And we'll move on to the next speaker, ma'am. We have
about maybe Ashwin, what would be the challenges in doing a phaco in a keratoconus eye? A point or two you have to say.
I think the points which you all have brought up is absolutely right. The only thing I would like to add is it really, in these keratoconus eyes, they become really deep. So, and when you have those deep chambers, you really want to be making sure that your angle of the phaco probe from the corneal wound is taken care. And that's something, because when you go down that much, you're easily going to penetrate. And these are softer cataracts, very, very soft. So you just take care of not going down too much and allow the nucleus to come to you rather than you going and fetching for it. Do some more hydrodissection to kind of pop that one pole up and then try and do a tilt tumble technique or just change your technique a little bit for that. That's my only tip on these cases.
Can I just ask a question? Yes,
yes, Anaga.
Yeah, excellent video, Dr. Ashwin. And I just wanted to ask you, you took a suture at the end of the surgery.
Right.
Was that, yeah, would it impact the astigmatism in any way, or?
It was a stay suture. Honestly speaking, the reason I did that also because this patient was getting a little hypotenuse. I don't know why. Maybe my incision was not as great as it should have been. But I'm guessing that these keratoconus eyes, they are a little more stretchy corneas. And so you just need to, I just wanted to be safe. Sorry for not having hypotenuse by the next day morning. That's my only reason. And it was more of a stay.
Regarding your question, Chitra, about anything different in these cases while doing phaco, just one point I want to make is very often the cones are in the inferior temporal direction. In extreme cones, the cornea is very soft there. So this is one of the rare situations where from a temporal clear corneal, I shift to a superior clear corneal, so that even my side port incisions are in the superior temporal and superior nasal, and leave the inferior temporal quadrant fairly untouched, because most often the weak cornea is right there, and
that's a very
use lower intraocular pressures right through the surgery.
Yes, very good.
Yes. IOL power calculation also would be really very difficult. We are here doing pupilloplasty and we could be really off the target, because of the extreme keratoconus. I think that is another thing which we have not touched upon here. This was a video based thing, but that also we need to look at.
Yes. Satyajit, do you want to?
Dr. Ajay Paul, you are muted.
You are on mute, sir. Can you please unmute?
Can I have a query for Ashwin?
Yes.
Ashwin,
yes,
how small is that the pinhole?
Yes, that's a superb question.
No, I have a patient who is post-RK, who's almost 24 or 30 scratches are there, very regular. We have tried out all sorts of measurement, but could not find out whether toric is around 5, 6, 7 every time it's showing. So we did think of doing putting a single, just a spherical lens or a plain spheric lens, and then do a pupilloplasty. So just to take out this astigmatism. So what would be your size that you suggest? Because at the end again you made it a bit round because for that to be seen. So
correct. I love this question, and I'll just answer very, very quickly, just in interest of time for everybody. But very clear, sir, RK has been one of our favorite topics in pinhole pupilloplasty because it has shown absolutely stunning results. The point which I'll say is 1.5 to 1.75 millimeters is, you cannot go more than that. I did a case, I made it 3 millimeters. I thought that's very small and that's very beautiful. But believe me, the patient was unhappy. The patient is unhappy with that vision. And unfortunately, what happens is we really have to get that measurement right, and we have to get it round. The problem, what happens is when you suture, it basically stitches like a cloth. The cloth comes together. You really have to go back and make that opening a little bit more with the cutter, or cutter is the best. A vitrectomy cutter, 25-23 gauge, whichever you use, is the best way to make that pupil absolutely round. And all the three, if you're using a Lumera or anything, whichever you use usually, those three lights is the first Purkinje image which you see, if that matches into your pupil. I would obviously, if you're doing this as the first time, I would definitely go ahead and mark the visual axis before you actually go ahead and into the eye and do this. But mark the visual axis before you do that surgery. Number one. Second is make it 1.5 millimeters and then open up that pupil to that mark. And that is the perfect way to do this. And RK has been brilliant for us in doing pinhole paproplasty. Those patients are very happy.
Thank you for those inputs.
Thank you, Dr. Ashvin. Wonderful video, wonderful discussion. Satyajit, can you go on with our next speaker introduction?
Thank you, madam. Thank you, everybody.
Thank you, Ashwin.